Hi. Um, Today, as the third part of lecture series on what is cancer, I am going to attempt to simplify some of the standard of care treatments that are prescribed for different types of cancers, and basically help you understand what is their mechanism of action, what is the purpose of this kind of treatments, why they vary from cancer to cancer, and basically take it from there. So historically, when it comes to treatment of cancer, I'm talking about many years ago, decades ago, the first reaction or the only treatment available at that time was surgery. So there was a lot of emphasis on removal or partial resection of a tumor. And surgeries were very radical. To give you an example, for example, for ladies with breast cancer, we had something called radical mastectomy. And what it meant was that the surgeon not only removed the breasts, sometimes both breasts, most of the time both breasts, surgeon also removed every single lymph node underneath the arm, as we call it, the axillary lymph nodes. And on top of that, they literally peeled off the muscles of chest walls of the rib cage. It was a very radical surgery. And it had many side effects. The most common side effect of it was what is called lymphedema, meaning that because every single lymph node was removed and resected from the underneath the arm, there was no natural or normal flow of lymph to make you familiar with what lymph nodes do and what the lymphatic system is. Parallel to our blood vessel systems, which basically they are centered around the heart. Major blood vessels, arteries come out of the heart, and then they go into all of our organs. And as they get to peripheral or, for example, fingers or toes, the blood vessels become smaller and smaller and smaller. And at the end, after they give nutrition and oxygen to all the tissues in the body, then they turn into veins. And veins are very similar to arteries, except that their direction is the opposite, meaning that they take what is in the tissues back into the heart. So arteries take blood from heart to the tissues, and veins take blood from tissues back to the heart. Parallel to this system, we have a system called the lymphatic system. And eventually, the flow of lymphatic system ends up in the heart as well. But it has these stations that we call them lymph nodes at different parts of our body, including neck, above our clavicle, underneath our arms. inside our abdomen, inside our chest, in our groins, all different parts of body. And the role is they play a major role in our immune system. Basically, these lymph nodes are all connected to each other through lymphatic vessels, which are not artery or they're not vein. They're completely different. They're vessels. There's this flow of a fluid which is very enriched with our immune system cells, such as white blood cells and lymphocytes and things like that. And the purpose of this whole system is really to identify what is called the enemy, which is not good for our body. It could be a germ, it could be a virus, it could be a cancer cell. And through this lymphatic system, they're drained into the lymph nodes. And lymph nodes almost act like little pumps that then pump the flow outside of themselves, and eventually these fluids, they all go back to the heart. Now, when the lymph nodes from underneath arm are removed, that pumping function that is required to pull all this fluid from the hands and forearm and the arm of a lady who had, say, left breast cancer, and they removed the left axillary lymph nodes. This pumping and this natural flow of lymphatic fluid from our fingers all the way towards our arm and then towards our heart would be disrupted, because instead of lymph nodes, then we have a bunch of scar tissue underneath our arm. And you might have seen ladies who had these form of radical mastectomies decades ago, and every one of them, without exception, would develop a side effect, which is called lymphedema. And what it is that their arms were very, very swollen. All their fingers were swollen, all forearm, arm, very swollen. You could not make a mistake just by looking at a woman whose right arm, for example, is normal and left arm is very swollen. You immediately knew that this lady has had a radical mastectomy. And this was permanent. There was really nothing to do about it. And this philosophy of the more radical surgery, the better, applied to all different kind of cancers. Because they didn't have radiation, they didn't have chemotherapy, they didn't have immunotherapy, they didn't have targeted therapy. So they had just one tool or weapon against the cancer. So they would do as much surgery as could. For example, if somebody had sarcoma, which is a form of tumor of the soft tissue, and it may happen in legs, it may happen in pelvis, it may happen in arm, they used to amputate that limb because there was just no other way. Same thing for bladder cancer, for example. For bladder cancer, nobody could keep their bladder. Once they had bladder cancer, they removed the entire bladder and the lymph nodes in the pelvis, and then they get lymphedema in their legs. For people who had, excuse me, colorectal cancer, they all ended up with a bag, colostomy bag, because they basically, that is for cancers which are a little bit lower closer to the anus, where the sphincter is. And because of that, a lot of people ended up with colostomy bag. Now, when radiation was introduced as a form of treatment for cancer, radiation initially, historically, unfortunately, was used for a lot of very, they use it very casually. For example, they used to use X-rays to measure the size of the shoes of people. So people go to buy a shoe and they would use X-ray to take a picture of their feet to measure the size of their foot and decide what size shoe is good for them. Or they used to use it in watches that you could see the numbers in the dark, and that was really giving you radiation. And especially in factories, people who made these watches, they were exposed to a lot of radiation. They used it for a lot of benign situations, such as acne. They used to give radiation to the faces of teenagers who had acne. It would treat their acne, but then it put them at much higher risk of developing skin cancer or cancer in the head and neck area, or especially thyroid, because each one of our organs in our bodies have a certain tolerance for radiation. Some of them are more sensitive to radiation than others. Two of the most sensitive tissues in our bodies to radiation are our lens in the eyes and our thyroid gland. So a lot of these people who got radiation, and they were not very precise because their machines were not really advanced technically, so they were targeting the face to take care of the acne, but radiation would be given to the lens, and people at very young age would get cataract. And those days they didn't have all these lenses that nowadays we have a cataract surgery. They take our lens out and they put an artificial lens in, and we have perfect vision. Once you had cataract, you would go blind. There's just no other way. The other sensitive tissue in that area is thyroid gland. So when they gave radiation to both sides of the face, chin, to get rid of acne, then later on, people become what is called hypothyroid, meaning that the thyroid gland would not produce as much hormone which was necessary for the body, and they would get, side effects of becoming hypothyroid. So initially, they used radiation very casually. They were very excited about it. They thought it was a very cool thing. And they were not aware that years later, these people who they were measuring their shoe size by getting an X-ray would get cancer in their feet. But as science grew and more studies and research was done, they learned that they could use radiation in a very scientific way to help the surgery. And basically, they did a lot of randomized trials, for example, for breast cancer. And radiation became a tool for what is called organ preservation, meaning that as opposed to when surgery was everything you could do was just surgery, the more the better, and often it resulted in loss of the organ whether it was breast or bladder or colon or a leg or a hand. Now, with the introduction of scientific introduction of radiation, organ preservation became a major advance in treatment of cancer. So, for example, in breast cancer, they did randomized trials for patients whose cancer was not very advanced. They could do just remove the lump or the tumor in the breast, but not do a mastectomy, and then give radiation to the breast. And that way, they could get the same outcome in terms of curing their cancer with much less surgery and without losing the organ. The same thing was happening with bladder. The same thing was happening with sarcomas. The same thing happened with a lot of head and neck cancers. In older days, if somebody got cancer of larynx or tongue or throat or sinuses, all they could do was just cut. And the more you cut, the better. The more you cut, the less the risk of cancer coming back, because radiation was not a part of the treatment. When radiation became part of treatment, they started organ preservation in head and neck. So in the example of breast, as the scientific use of radiation was increased in treatment of cancer, naturally the severity and the extent of surgeries were decreased, because randomized studies showed that there's no advantage of removing the whole breast if you just remove the tumor and gave radiation to the breast. So why do you do that? There was no advantage of removing every single lymph node, because you could give radiation to underarm, and therefore people would not get these permanent lifetime lymphedemas. The same thing with sarcomas. With sarcomas, now it was a little bit later on, and it was with the introduction of chemotherapy. Chemotherapy can be used in two ways. Chemotherapy can be used as what we call a radiosensitizer, meaning that low doses of chemotherapy concurrently given with radiation would make radiation more effective, and therefore less doses of radiation were necessary to kill the tumor. Also, chemotherapy can be used just by itself as a modality to either prevent or treat cancer that has traveled to outside of the originating organ. So, for example, for breast cancer, depending on the stage, these are all depends on different type of cancers, different kind of stages. So for early stage breast cancer, when the lymph nodes are not involved, chemotherapy is not a necessity. Women don't get chemotherapy. If they don't want to have a mastectomy, they would just have what is called a lumpectomy and radiation. And if their tumor is a type of tumor that female hormones such as progesterone and estrogen feeds them, and makes them grow, then they would take a pill. Then it was 5 years, now it's 10 years. They take the pill to prevent the cancer from coming back. For sarcomas, for example, what they did as a part of organ preservation, the same thing with bladder cancer, was that they gave a combination of radiation therapy and chemotherapy first to shrink the tumor. And then, instead of removing the entire bladder or amputating a limb, they could just remove the tumor and get the same result. And then for head and neck cancers, in many cases, a combination of chemotherapy and radiation became the standard of care, and surgery was not necessary unless the tumor did not respond to chemoradiation. So when we look at evolution of using these different modalities over the period of time, we have moved toward less and less of surgery and more use of radiation and chemotherapy. But as we continue to do research and randomized studies, our goal is to give just enough radiation or just enough chemotherapy to take care of cancer, but not too much. So we went all the way to an extent that we were giving a lot of chemotherapy and radiation. And then Europeans are very good at this. And part of it is really financial because they have national health care. And really one of the incentives is that, okay, the less treatment, the better. So for example, when I started practicing in 2000, 21 years ago, it was the beginning of cutting back on the amount of radiation or the amount of chemotherapy, sometimes completely replacing radiation with chemo. They were using different studies, different research to see with how little of radiation, how little of chemotherapy they could get away. So, for example, when I was being trained for radiation therapy, 5 to 6 weeks of radiation therapy for lymphomas, and even some of the Hodgkin lymphomas. We have 2 types of lymphomas. We have non-Hodgkin's and we have Hodgkin's. I don't want to go into too much detail. But Hodgkin's lymphoma historically has always been treated with radiation alone, but with a higher dose of radiation. But unfortunately, because a lot of people who get Hodgkin's lymphoma are young, in their teenage years or in their 20s, and they lived long because radiation cured their Hodgkin's lymphoma, then they started developing secondary cancers as a result of radiation. So 10, 15, 20 years later, after they had gotten radiation to cure their Hodgkin's lymphoma, and because in Hodgkin's lymphoma, we gave radiation to all the lymph nodes in the neck, all the lymph nodes above clavicle, all the lymph nodes in the chest, depending on the stage, sometimes all the lymph nodes in the abdomen and pelvis, a lot of organs were exposed to a lot of radiation, including thyroid, including the medial part of breast in women, parts of organs in the abdomen. And then a young lady who got Hodgkin's lymphoma at age 17, now 10 years later at age 27 or 20 years later at age 37, developed breast cancer. And this breast cancer was directly as a result of the radiation we received. So now the science was thinking, okay, we have a problem here. We are curing something, but then this very thing is causing secondary cancers down the road. We need to find a fine balance between how much radiation we give to be adequately treating, so for example, Hodgkin's lymphoma, but by reducing the dose of radiation to the normal tissues, then we need to reduce the risk of secondary cancers. So I clearly remember that in 2000, when I started practicing after completing my residency, there were multiple studies from Europe that they were looking at 2 to 3 weeks of radiation with chemotherapy to treat Hodgkin's lymphoma instead of giving them 5-6 weeks of radiation. And they could get the same result, but they had lower risk of developing secondary cancers. So this trend continues, meaning that we are always in search of a fine balance in giving enough of any modality to treat the cancer, but not that much to cause another cancer. Generally speaking, we as radiation oncologists, we have standard of care, we have guidelines, we have annual meetings, we have constant research that keeps us up with what is the standard dose for example, for prostate cancer or for head and neck cancer, or for lymphoma, for non-Hodgkin's lymphoma, for breast cancer. And we are constantly doing two things. Radiation therapy is very much dependent on the technology. It's a very, very technologically demanding field. For example, a radiation oncologist such as myself, after finishing medical school and after finishing internship in internal medicine, we had to do 4 years of residency in radiation oncology, and we were the only physicians who were taken back to being taught physics and biology, but radiobiology, physics as it was related to radiation. Very, very much technically demanded in that understanding of biology of how radiation affects cancer and normal tissues, and also how technology can help us minimize radiation to the adjacent normal tissue. We do have two types of radiation therapy, in the sense that we have a type of radiation that is called external radiation therapy. And then we have another form of radiation that is called internal radiation. And for external radiation, there's just no other way than radiation coming from outside, from a radiation machine, to target an organ which is inside of our body. So we call that external radiation. And then we have another type of radiation that we call internal radiation, or the technical term for it is brachytherapy. To give you an example, brachytherapy or internal radiation can be used in prostate cancer. There are radioactive seeds that we can implant inside the prostate. And this way, radiation is not coming from outside. Radiation is implanted in the prostate gland. It's called radioactive seed implant. And these seeds would be there permanently, but they would not be permanently radioactive, because any radioactive material has a lifetime. They decay. As they decay, they give out less of radiation. So these seeds are very well calculated as how long, because there are different types of them, as how long they would be radiating the prostate. And once they decay, they become inert, meaning that the seeds are there, but they're not giving any additional radiation. Their lifetime for emitting radiation ends at a certain point. The advantage of internal radiation is that there would be a whole lot less radiation to the adjacent organs, because if we are targeting prostate gland from outside, this is a deep-seated tissue in the pelvis. And when the external radiation is going, targeting the prostate gland, no matter how well our technology is, it has to go through normal tissues to reach the prostate gland. But when seeds are implanted inside the prostate gland, they are giving radiation from inside. There will be some radiation to the adjacent organs, such as rectum, which is right behind prostate gland, or the tube that brings urine from bladder out and goes through prostate gland, called urethra. There will be some radiation to urethra, but it's minimal. We also use internal radiation for treatment of cervical cancer or endometrial cancer, generally female organ cancer. But depending on the stage, if they're really, really early stage, they can get away with brachytherapy alone. But if it's a little bit more advanced, then it's always combined, a combination of external and internal. And the reason that we combine them is that we cannot give that high dose of a radiation that is necessary to kill the tumor all from outside, because our normal organs, for example, a woman who has cancer in the cervix or in the endometrium, there are so many other organs in the pelvis. There's bladder, there's rectum, there's bowel. There's the pelvic bone that if you give too much radiation causes fracture. So we use a combination of external and internal to achieve the required dose to get rid of cancer, but really minimize radiation to the surrounding adjacent organs. So One of the things that I really love about radiation oncology is that it changes constantly. The technology changes constantly. And when people ask me like where I should go or, recommend a radiation oncologist, my first recommendation to them is first find out what kind of technology they have. Because even if you have the best radiation oncologist in the world, but she or he is working at a center where they do not have advanced technology, they are very limited in terms of what good of a job they can do for you. It's like, you have an advanced computer with new software, all kind of different softwares. That computer can do a lot of things for you. But if you have an old computer, it's slow, it's very limited in terms of what you can do with it. The same thing with radiation machines. It's very, very important that whatever center somebody goes to get radiation, they do their due diligent research to find out what kind of technology there is. To give you a little bit of idea about that, I remember when I was a resident, I was doing research on a new form of radiation therapy called three-dimensional radiation therapy. Because before that, the type of radiation we were giving was called two-dimensional radiation therapy. And this was the way we were doing it during my residency. The patient would come, we take a plain X-ray, just like a chest X-ray, but depending on wherever the tumor was, we took like a plain X-ray, and then with wax pencil, literally with wax pencil, we would draw the area that needs to get radiation. And the only way that we could check it to make sure that we are on the target was that once a week, we repeated that X-ray while the patient was getting treatment. And we were looking at the marks that we had placed on the body of the patient to make sure we are on the dark. It was very primitive, very primitive. And because of that, we could not give very effective doses of radiation because we're limited by how much radiation the surrounding organs could get. And literally every organ next to the target or the tumor was inside radiation field. The best we could do was use 4 direction, front, back, side to side, which meant if I give X amount of radiation to the tumor, at each direction, the normal tissues on the way of tumor were getting a quarter of the dose. And a quarter of those to those normal tissue was a large number. Because of that, I remember the days that for prostate cancer, we could not go more than 6,000 units of radiation, which was about 6 weeks of radiation. And they had a lot of side effects during treatment. They had a lot of side effects after treatment. And we didn't have a lot of success. I mean, relatively compared to some other cancers like pancreatic cancer, we had a better success rate, but we had a lot of recurrences because we couldn't go more than 6,000 because we couldn't permanently damage the surrounding normal tissue. So when I was doing my research on three-dimensional radiation therapy, that is when CAT scans had become invented, and now we were using CAT scans. So instead of getting a plain X-ray. We would get a CAT scan of the area, and then we had the software in the computer that generated a 3D version of the body of patient, that part of body of patient. So we could, in computer, we could rotate it, we could look at from different angles, we could use many, many different angles of radiation. And by doing so, we were able to gradually increase the dose of radiation to the doses that were curative for the cancer, while minimizing radiation to the surrounding normal tissue. And this was a huge achievement. Nowadays, a gentleman with prostate cancer gets about 8,100 units of radiation, sometimes more, which is about 2,000 units of radiation more than when I was a resident. And because of that, the success rate is very, very high. There was a time, just like breast cancer or sarcomas, that any gentleman who got prostate cancer, their only option was what is called radical prostatectomy, which would just remove the prostate, lymph nodes in the pelvis, and unfortunately, a lot of nerves were damaged during this type of surgery, so they became incontinent, they become impotent, which was obviously not a way to live. And these days, my patients just breeze through 9 weeks of radiation therapy without any side effect, or very, very little side effect during or after radiation therapy. So what is promising about the field of oncology in general is that every year we have something new. In radiation, generally it's a new technology. In chemotherapy, generally it's a new agent or different mechanism of action. Today, I'm not gonna talk a whole lot about chemotherapy, or in general, what we call systemic therapy. To make that clear, surgery and radiation are considered localized therapy. They deal with the issue where it started. So if it's breast, they deal with breast, whether it's surgery or radiation. If it's prostate, they deal with prostate. Systemic therapy, which has many different forms, but chemotherapy is the most common form of it, is something that by injecting chemotherapy in the blood vessels, they go everywhere. And that is like a double-edged sword. It's good that it goes everywhere, because if any little cancer cells have broken loose from the tumor and they have traveled through blood vessels and they're all planning to sit in the liver or lung or bone and start growing, chemotherapy kills them. You can't really, with some exceptions, you can't give radiation to the whole body of a person. It kills them. Because bone marrow, which creates our red cells, white cells, blood cells in general, they are inside of our bones and they're extremely sensitive to radiation. That is why in Hiroshima, where an atomic bomb exploded, and it exposed the entire population to very high dose of radiation. Their bodies melted. There are stories that people were walking and their flesh was falling off their bodies because the very high dose of radiation they received. And even those who were pretty far from the center of explosion, they got enough radiation that later on developed leukemias or all different kinds of cancers. And because of that, radiation is generally speaking not used as a systemic therapy. We don't go after every single cancer cell by radiating all part of the body. We focus on the primary tumor where it started. And the rest of the body is taken care of by systemic therapy. So one example of systemic therapy is chemotherapy. Another example of it is hormonal therapy. For example, ladies who have breast cancer, they get this pill called tamoxifen, which blocks the effect of female hormones on the breast cancer cells and prevent it from coming back. So gentlemen with prostate cancer, they can get hormonal therapy. They get Lupron or other forms of hormones that blocks the effect of testosterone on prostate cell cancers, because prostate cancer cells feed on testosterone. That is not for the rest of their life, but anywhere between 6 months to 2 years, depending on the stage of the cancer they have. And in the past decade or so, so many different other ways of systemic therapy, such as immunotherapy, targeted therapy, vaccine therapy, which is a form of immune therapy, they have been invented, which gives so many options to cancer survivors. Even when we talk about chemotherapy, we are talking about apples and oranges, because they're different agents of chemotherapy. And we don't use the same agent of chemotherapy that we use for breast cancer, for colon cancer, or lung cancer. Every cancer has its own specific agents, which none of them have been chosen randomly. These were all based on randomized studies, comparing what chemotherapy to the other, and scientifically proving that this chemotherapy is better for this cancer and that chemotherapy is better for this cancer, and how much to give, how many cycles to give, when to give. Do we give chemotherapy before radiation? Do we give chemotherapy after radiation? Do we give radiation concurrently, chemotherapy and radiation concurrently? It varies from cancer to cancer and stage by stage. So the good news is that we're constantly inventing new things for treatment of cancer. We're constantly advancing the technology when it comes to radiation, to surgery. We have robotic surgery now that minimizes the size of the incisions they used to give. Somebody had, surgery, they would literally open them from the rib cage all the way to pelvis, huge scars, a lot of scar tissue inside the body. Nowadays, a lot of surgeries are done laparoscopically, which is done through just a hole or a few holes. So recovery from surgeries are easier. Surgeries themselves are safer. So nothing in treatment of cancer is done randomly. Everything has been studied to death. We continue to study in our annual meetings. Every year we have new data. Every year we have new treatments. Every year we have new technology. And that is what I love about this field. I never get bored, and I have to be updated constantly, because a treatment that maybe last year was the standard of care, this year is no longer standard of care. And that's great, because there's a lot of promise in what can be done next year, what can be done 10 years from now, because things are constantly advancing. So I would stop here with the little discussion about evolution of role of surgery and radiation in treatment of cancer, and maybe next time emphasize more on systemic therapy, different types of systemic therapies, that they are chemotherapy, hormonal therapy, immunotherapy, and what is their mechanism of action, and targeted therapy, which is amazing. Targeted therapy literally means that the treatment we give targets cancer cells individually and spares the normal tissue. And that is a very, very exciting field in oncology, because then patients have less side effects. They can tolerate their treatment better, and the results are better because it's targeted. It's just like really, in a way, very similar to wars. Even though war is not a good thing, but it's a good analogy, that, used to be that they would just throw a bomb on an entire city, and yeah, they would kill the soldiers, but they kill a lot of casual people who had nothing to do with the war, but they couldn't target better. The best they could do was target a city. Now they are so advanced that they can literally target a single house in a city and say, okay, we are targeting this address, and drop whatever the bomb, whatever it is, just right on that house where the enemy is, and save the rest of the houses in the city. That is really very similar to what is called targeted therapy in systemic therapy in oncology. And I will try to expand on that maybe next week. Thank you very much, and hopefully I would see you next week.